Good afternoon, everyone. Welcome again. It's great to see you. Thank you for joining us today. Last week, we had the first webinar on this series. We focused on our persistent severe hypertension measure, which is our aim. And there are some nuances to the measure, so it's very important that if you didn't see it, that you please take the time to review it, as this is a follow-up webinar to that one. Today we have a packed agenda, so we're going to move forward. But if you have any questions, we do have two sections in the webinar where we're going to be taking questions. Next slide. So just a couple of housekeeping items. Please mute yourself. We want to minimize the background noises as much as possible. If you have a question, please make sure to enter it in the chat or raise your hand. And then when we get to the question section, we'll call you. So you can share your question. This webinar is being recorded, and all our recordings and all the documents, slide decks, everything will be available to you by early next week. The first webinar is actually already in our YouTube channel. If you are looking for it, it's right there. Next slide. So I think I've met many of you. For those that I haven't met, my name is Estefania Rubio. I am the Associate Director of Healthcare Data and Informatics here at the Florida Perinatal Quality Collaborative. But in our data team, we have two very talented data analysts. Both of them are going to be taking you through the bulk of the email today. Shelby joined us last year. She is a public health professional. She did her master's in public health here at FQC, and then she did a concentration on maternal and child health and epidemiology. She's very well trained, and she's very quick to answer any of your questions when you have them. So please make sure to reach out when needed. Alexa joined us just 2.5 months ago. She's our most recent FQC team member. She has a bachelor in economics and then a master's of public health and policy with a concentration of policy analysis that she's about to finish. She's going through those very last courses. But again, a very talented data analyst, ready to help you with any questions you may have. Next slide. So we are just going to do a very quick recap of the measure, what we covered last week. So let's remember, we are going to focus on persistent severe hypertension. And for our definition, we know that severe hypertension is a systolic blood pressure of 160 or more, or a diastolic blood pressure of 110 or more, or both. So what makes it persistent? First, one or more repeat severe hypertension observations documented 15 to 60 minutes after episode onset, right? So it may be the classic where you have back-to-back severe range readings within 15 minutes, and that's your persistent severe hypertension, but the values don't need to be consecutive within an hour. So if you have two severe ranges within an hour, that is also persistent severe hypertension. But there's another nuance that is very important, and that is for documentation purposes. We are looking at blood pressure that was not documented to have decreased to non-severe hypertension within 15 minutes. What does this mean? If we have one severe reading and then the patient wasn't checked within 15 minutes again, then that's immediately considered a persistent severe hypertension episode because we didn't provide proof that the blood pressure dropped before that 15-minute check, right? So that is a very important aspect because that is a gap in patient quality that or patient safety that we can work on. So those are the two definitions that you need to remember for persistent severe hypertension. You may have two severe ranges or more within an hour, or lack of documentation within 15 minutes. That is also considered a persistent severe hypertension episode. Next slide. Another consideration is that we are going to focus on our population to focus as pregnant at any gestational age or postpartum women up to 6 weeks that present to your hospital with persistent severe hypertension, right? So those are the ones that you're going to include for abstraction. And also, you are only going to include the first severe episode per admission. So the patient may have multiple severe events. We are only including the first one. And that is just to help with the chart abstraction so we can have the workload not be extreme, right? We are going to do that for our abstractors so it's manageable. Okay, next slide. Now, there is something that we need to make sure that we clarify. We are doing the 15 blood pressure check for documentation and for data and case identification only. For monitoring and management, the recommendation is quite different, right? For monitoring and your blood pressure check, you need to remember that that needs to be frequent. And that is essential as part of your patient safety goals, right? So if you have a severe range, ACOG recommends that you repeat the blood pressure every 5 minutes for the first 15 minutes. So that means you would have your severe event, and then you recheck at time 5, 10, and 15, right? And then from there, depending on the medication that is chosen, you would recheck based on your algorithms. But it's very, very important that you don't confuse case identification, which we're going to look for a confirmation within 15 minutes, versus blood pressure monitoring for your patients that needs to be frequent to be a par with the guidelines for patient safety. All right, next slide. So let's go back to case identification, right? And this is for my abstractors. When you are going to be looking at which cases to include for FPQC data abstraction, you first need to identify which ones you are going to include, right? So based on the definition that we have for persistent severe hypertension, please look at the graph. The grid basically has your time at the top. So you have from time 0, all your severe episodes, and then every 5 minutes, you see that we have a blood pressure check in there. So N is non-severe, and then S is your severe events. Looking across, please check all those cases that would be considered persistent severe hypertension.
All right, now we've got about 50% participation. So we'll wait one more minute for that other 50% to get your answers in.
Thank you for putting in your answers, everyone. And please make sure to check across.
All right, for time, we'll go ahead and stop and share our results.
Wonderful. Okay, so 83% A, 9% B, 93% C, and 56% D. I think most of you got it correct. So let's go to the next one. Our result, the correct answers were A, C, and D. And so if you look at A, you have 2 non-consecutive severe ranges within an hour. So that fits the first definition, right? We have 2 non-consecutive events. B, you only have 1. Luckily, this patient was rechecked by 15 minutes. So, then she has a non-severe event. And if you track it through the hour, all of the other timings were non-severe. So we know that this patient did not have persistent severe hypertension as her diagnosis. For C, we do have 2 severe events back to back. So this is the classic presentation, right? Consecutive values. And then lastly, the last one, we have 1 severe event, and then this patient, unfortunately, was not checked within 15 minutes, right? ACOG recommendation says after 5 minutes, but the measure is much more lenient. We're looking at least the patient was rechecked within 15 minutes. This patient was not. So because of lack of documentation, and because this is a gap in patient safety, again, this would be classified as a persistent severe hypertension, and you should include it in your abstraction. All right, thank you so much for your participation. Next one. All right, so the next of the webinar, we're going to focus on data for improvement, our data collection forms, what types of data we have, and some of the submission processes. So Shelby, take us through it.
All right, thank you so much, Stephanie. Can everybody hear me all right?
Yes.
All right, thank you. Okay. So I want to start us off to remember our why and our how for data collection and quality improvement. So all of us are quality improvement champions, and we have to reconsider the why for this data collection process. So first and foremost, it informs our progress and outcome of the work that we're doing. It helps us evaluate how our team is doing from the baseline all the way to our goals and throughout the process. While we're evaluating ourselves continuously, this data helps us to check in and identify areas where we're doing well, our strengths, and where we could be doing better, or maybe areas of opportunity. All this data is for learning, essentially, not for judging ourselves, but to really enhance how we're learning throughout the QI process. So next I want to talk about our how and how we're using this data for improvement. Just basically relying on administrative data sets or ICD-10 codes really isn't enough. Our QI data adds to all those data sets and really paints us a bigger and brighter picture of what is going on with our patient outcomes. So your initial data points is going to serve as a surrogate baseline. So all of us collect, the first 3 months of data to establish where we're starting from. And then we continuously review this data every month for evaluating and guiding improvement. So like I had said, you are using it to prompt your discussion, highlight the strengths and areas of opportunity. And then lastly, creating a system that can be maintained long after the project ends. So we can start from our baseline and continuously evaluate ourselves and keep the system of evaluation way after the 18 months has ended. So another reminder is that data needs to be strong, detailed, and actionable. So the better we prepare and plan and create a strategy for data collection and evaluation, the stronger that our systems can be throughout our QI work. All right, so next, before we dive into all the specifics of our data collection, I wanted to bring our focus to our aims. So the aims for prompt is that by June of 2026, we will increase by 20% percentage of patients receiving timely treatment for persistent acute onset severe hypertension within 1 hour from the first severe range blood pressure reading. And then next, the appropriate discharge education and scheduled follow-up encounters within 3 to 7 days post-discharge. So like I said before, the patient level baseline is going to be established after the first quarter of hospital data. So in January, when data collection begins all the way throughout March of next year, those 3 months all added together is going to reveal us our baseline and where we're starting at as an initiative whole. All right, and so here is our key driver diagram that all of you guys have seen in the kickoff and our other meeting before, but I just want to bring our attention back to that process precedes outcome. So all these secondary drivers or our process measures are what we can work on, the small changes that we can evaluate in order to achieve those aims. So a lot of times we look from the aims forward, but really we're looking backward in this direction of causality, starting with our process measures and our secondary drivers and working our way to our aim. All right, I'm going to pass it over to Alexa.
Okay, so in this section, I'm going to go over briefly the forms and the tools that we're going to use for data collection. And this is really going to allow us to look at the data over time and determine whether the changes that were made actually resulted in an improvement or not. Next slide. So the overarching categories for data in this initiative will be monthly level, patient level data. Those will include things like demographics, time to treatment, education provided, tools provided, and appointments scheduled. We will also have you submit aggregate severe maternal morbidity patient level data quarterly, along with your hospital level data quarterly. That's very similar to previous initiatives where you put in things like staff education and policies and guidelines that you've made. So on the next screen, we'll be going over the monthly patient level data. So for the focus population, the inclusion criteria will include all pregnant and postpartum women up to 6 weeks that present to either triage, your ED, your OB-ED if you have one, antepartum unit, labor and delivery, and or the postpartum unit at your hospital that have persistent severe hypertension. And as a reminder, persistent severe hypertension is defined for this initiative as a blood pressure of 160 or greater systolic and 110 or greater diastolic, and one or more repeat severe hypertension observations have been documented 15 to 60 minutes after the onset episode. And as you've seen, they do not need to be consecutive. Or if they had a severe hypertension reading, it was not documented to have decreased to non-severe hypertension within 15 minutes. And the exclusion criteria are those patients without persistent severe hypertension. So we're really including every patient that comes in pregnant or postpartum up to 6 weeks that has any sort of severe hypertension event. So this is what the patient level paper form looks like, and you'll see in a minute that the REDCap will reflect this as well. So the first section is the demographics. This is pretty self-explanatory, and we'll be going over it in more detail in a second. The bottom left has the time to treat. This is a medical management table where you will start to mark time and location of certain events. So blood pressure reached this severe range, the confirmatory reading, medications given, etc. And then underneath that is where you'll mark which medications were given, whether you marked followed protocol and which the first medication was, and any reasons why you maybe didn't give medication to the patient. On the very bottom left, we have adverse effects. They're really balancing measures that we're going to look at to make sure that any interventions that we're doing are not causing harm. And then on the mid-right, we have our adverse maternal and neonatal outcomes, as well as our debrief and review questions. And on the bottom right, we have questions about discharge management. So the demographics, relatively straightforward. You've got ethnicity, race, primary language, insurance. You also have your study ID up at the top right. That is a 3-digit code similar to what we've done in previous initiatives. It should start with 001, and it should be, you should continue forward with that throughout the entirety of the initiative. So 001, 002, etc. So they should be consecutive throughout the entire initiative. So if you end your first month at 015, your second month should pick up at 016. And this data is really going to help us inform our case composition and track our population change over time and over the initiative. And it'll allow us to disaggregate measures to identify certain groups or populations that might have differences in outcomes. I'm going to hand it over to Shelby.
Thanks, Alexa. Okay, so now we're looking at our medical management or time to treat event box. So this box is where we're indicating the very first severe hypertension reading. Your first box here is, your first reading. Our time is in a 24-hour format, and then the location here to the right. The second line is that confirmatory blood pressure reading that's in the severe range. The third line is going to be the same as the first. If it was done in an OB unit, but the third line is there as the first severe hypertensive reading that's in an OB unit. So let's say, for example, your first severe reading is in an ED department, then your third line might be different. But if it was in an OB-ED department, then the first and the third line are going to be the same. Your fourth line is the time and the location of that first blood pressure medicine that was given. And then the last line is the time and the location of the first reading that was in a non-severe range. And our letters over here, we've got, EMS, emergency department, OB, ED. The T stands for triage. Then we have AP for antepartum, LND, and then PP for postpartum. Next, we've got our medications listed here. So you'll notice that this is the very first medicine given, so only choose one of these here. You can see we have a column here for followed protocol. So protocol is going to be established by our hospital unit. We have example protocols that will be available in the toolbox. So you can see some examples of that, but we leave it vague so that way you and your hospital team can come up with the best protocol, or maybe you already got one established. So that is what that column is for. Make sure we went over here. And at the bottom here, we also have if a medicine was not given, we've got a option for you to choose why it was not given. And then next we have balancing measures. So like Alexa already talked about this earlier, we want to track these measures to make sure that the interventions are not causing harm. Hypotension after appropriate antihypertensive treatment is uncommon and rarely leads to fetal compromise requiring immediate delivery. But we want to have it here, like we said, to balance it out. And if that rare event does happen, we have it monitored and tracked here with, the following 3 questions: if there was deterioration in fetal heart rate, or, if interventions for the hypotension were administered, and then also if a cesarean was performed due to this hypotension. Next, we've got our adverse outcomes here. So this list is not extensive. We've got some, common adverse outcomes listed here. We've also got an other section for you to write in any other adverse maternal outcomes that might occur. If you notice, there's not death is not an option on here, so we are not tracking deaths. And you've got any adverse neonatal outcome, as well as a section here at the very bottom to choose if a debrief was done to talk about various opportunities for improving the overall treatment. And then also, lastly, if it was a SMS case, was there an interdisciplinary case review conducted? Yeah, and like I said, that other could be any other adverse outcomes that are not listed here, excluding death.
Okay, so the last part of the patient level data is the discharge management. It's a series of yes or no questions, relatively straightforward. Were verbal and written postpartum warning signs given to the patient? Were they verbally debriefed on their persistent severe hypertension before they were discharged? Were they discharged on meds? And if so, were the medications given prior to discharge? Were they given a blood pressure cuff prior to discharge? And was a postpartum discharge assessment conducted just prior to their discharge? And we also are looking at how many days after discharge were appointments scheduled, and this is a check all that apply. We're hoping to see that the blood pressure and symptom checks were given within 3 days, and that also other follow-up appointment was scheduled within 21 days. So you have the 4 to 7 days, 8 to 14, 15 to 21, over 21, and then a patient was instructed or not scheduled. And just as a note, I do see some hands raised. We have a section for questions coming up shortly. We'll get to those. Next slide, Shelby. Thank you. So for those of you who are in PAC, this will look very familiar to you. This is our postpartum discharge assessment that looks for certain vital signs and tells you what to do if those vital signs are within a certain range. We're hoping that all hospitals will start to implement this for all patients, and it will allow us to cast a wider range and catch those patients that may end up or be at risk for severe hypertension. And this is an example of something that you could use as that postpartum discharge assessment that we're tracking to see whether it was completed or not. But for those of you who are in PAC, you may already have this established, and that is great. that will be an easy check mark for you on the discharge management section. Next slide.
Okay, so now we're going to get into the nitty-gritty of the steps for data collection and abstraction. We're going to get into a step-by-step of what this looks like. So first, now that you guys have seen the severe hypertension patient level data form, our hope is that, you know, all patients with new onset persistent severe hypertension are using this sheet. So your staff has one of these sheets for every new onset persistent severe hypertension case, and you're filling it out as you go along. And then also using chart review coupled with this sheet to collect discharge and outcome data. And so, in that way, you can use your EMR to identify all patients with new onset persistent severe hypertension to ensure that you've captured all cases. Like I said, you're using this form for all patients with new onset persistent severe hypertension, but you're only submitting the first 15 to the FPQC, and we'll get into what those 15 patients look like in a second. And just a reminder, the link to the forms online will be sent to your data lead once the DUA is fully executed. So in chart review, we're doing retrospective chart review using ICD-10 codes for preeclampsia diagnoses and L&D, ED, triage, antepartum, and postpartum. Also, EMR searches utilizing keywords for pregnant and postpartum patients such as chronic hypertension, preeclampsia, the whole preeclampsia spectrum, preeclampsia with severe features, systolic blood pressure over 160, and diastolic blood pressure equal to or above 110. Also, other places to look include delivery logs and pharmacy records for labetalol, hydralazine, nifedipine, and magnesium sulfate. So all good places to look for chart review, looking backwards. This is the ICD-10 codes from AIM. This will be available for all of you to use and sent to you with all of the data collection instructions, so you can have those quickly accessible. So we've got some more steps. So you're using that form with all of your patients that have new onset persistent severe hypertension. You're also using EMR to look retrospectively and identify other patients with persistent severe hypertension, just to make sure you've captured everyone. And then with all this data collected, you'll find your sample of up to 15 patients. So hopefully your patient already has a form. You can go back in time, take out those forms, look in your EMR and update the information with the outcome data. But if not, then you can use chart review like we just went over to collect discharge and outcome data. So next we're going to get into your individual patient level monthly submission, or those 15 cases. So every month, you guys are going to report on up to 15 cases of pregnant and postpartum patients with persistent severe hypertension that presents to ED or your OB unit. So the first 10 are going to be the persistent severe hypertensive cases, excluding those with severe maternal morbidity, because the remainder 5 are going to be the severe maternal morbidity among preeclampsia, eclampsia, HELLP syndrome, and so forth. So those are your 15. Again, that's a max of 15. We have a lot of smaller volume hospitals on with us, and so if you're not getting 15, you just report on however many you have up to 15. So if it's 8 and 2 and that's 10, then you report 10. A lot of you already have, you know, a log for your patients that you're submitting to FPQC. Keep up with that same method of data abstraction if that's working for you. You might have an Excel spreadsheet that you and your team are already utilizing that works well. If not, and this is new to you in your hospital, we have an example of a log that works for a lot of hospitals that will be on the data abstraction instructions that will be sent out to all of you. You could use this to take it into Excel and make something that works for your team. Whatever works best is the best method to use for you and your team. All right, so we're using our form, we're looking through our EMR, and now we've gathered our 15 patients. We've went back in time, we've looked at our discharge and outcome data, and now we're ready to enter in our abstracted patient sample to the FPQC. Well, we've already submitted our DUA, that's passed, and now we have our REDCap links. So we go into our REDCap links before the 15th of the following month. So like in January, all of you guys are going to start this data abstraction process. When January ends, you have until February 15th to go into REDCap and to submit your 15 patients. And again, you'll get those REDCap forms. Once the DUA is fully executed, Alexa is going to take us through a cool demo of what this form looks like on your end. So now is our break for questions. So I see a couple hand raised. Let's see.
Rose, you've had your hand up for a while.
Good morning. Yes, I just wanted to clarify when we're submitting this, that if a patient in the scenario you said comes to the ED first and then comes to OB triage, if they have a increased pressure in the ED, are we starting our time frame from that moment as far as capturing the data when we treat and when we put that the information in the form, or are we going to start that data from the time they actually get to the OB unit?
Hi,
Data review. Thank you.
That's a great question. Shelby, if you don't mind, I can take that one. So we are going to collect your information from the ED if you are able to access. That is absolutely fantastic. But for the measure for time to treatment, we take the time when the first severe range occurred or was documented in your obstetric unit. So if it was in the OB/ED, then the time starts in your OB/ED for the first severe range. And then you have 60 minutes from that first reading in your obstetric unit. And that is just a way to standardize the measure. That is part of the SMFM paper that went out and that we're following. It's great guidelines, and that allows us to standardize for the state, because we know that some hospitals have that great connection with the ED and they are able to access their data sets, and some places don't. And so just to standardize and to be able to compare the same thing across units, we are going to do it from the first severe reading in the obstetric unit.
Okay, so may just repeat that so I make sure I have that in my brain. So we're going to document if we have access to the ED, which we do, that blood pressure, but we're actually not going to treat until we have 2 on our OB unit.
No. So treatment, it would depend on your protocol. I'm sorry, let me go back. So for clinical management, you should do what your protocol allows. If your hospital is able to start treatment in the ED right after you take the first confirmatory blood pressure, right? You have the severe event, the severe range, and then you have the confirmatory range, and then you can start treatment right away. That's wonderful. And we will collect that information. That's why you can let us know where all of that was documented, and the ER is part of that. For data collection and for data reporting, we need to standardize the measure. And so we are going to track how treatment is done from the time it's recorded, wherever it is. If you have access to the ED, triage area, wonderful, we'll do it from there. But for the comparison statewide, we are going to go with the obstetrical unit, right? So that is something that we need to make a very big differentiation. If you have a protocol and you're able to start treatment right away in the ED, that is a wonderful, fantastic practice. That is great. For those that don't or cannot access the ED information, then we will be asking you for the OB/ED information, and we are going to report that measure based on that. So basically, in your report, you will have 2 measures. One that tracks what you are able to do with your ED, and then the other one that tracks only from the OB/ED treatment time So you can compare statewide with something that is more standardized. Does that help, Rose?
Okay, yes, I think so. Thank you.
Thank you. I appreciate your questions. Great.
Michelande, is that how you pronounce it?
Echelon, yeah, that was actually pretty close.
Thank you. 4 years of French really paid off.
That's wonderful. Have a quick question on the measures under the medical management. So you were mentioning that, okay, so that last row is the first time that we had a non-severe BP, but then you were saying that there were two that potentially could be the same. And I was trying to figure out which rows it would. Is it because if we don't have an OBED and they're seen in L&D first, that means that that first row and that third row would be the same?
Yes, so the first row is, and I'll go over this when I do the REDCap demo also, the first row is where the first severe reading happened. If it happened in EMS or ED, then your first and your third rows are going to be different. If it
Okay.
happened in OBED, triage, antepartum, labor and delivery, or postpartum, then the first and third rows will be the same because the third row is specifically asking when the first severe reading happened in OB unit.
I see.
Does
Okay.
that make sense?
Yeah, it does. Thank you.
Sure. Shamika?
Hi, yes. So on the form, there's a section when it comes to the discharge planning that talks about if we discharge a patient with a BP cuff or not. I was wondering because Lee Health, we do a lot of remote patient monitoring. We set the patient up with that. Would that count if we didn't discharge them with a physical cuff, but we did set them up on remote patient monitoring?
Yes, that would absolutely count. We only check if the patient had a BP cuff. So if they had the remote, they still have some way to monitor. So that would
Okay,
be.
thank you.
Thank you, Shamika. That's a great question.
Let's go with Nell.
Not sure if that was.
Yes, hi.
Oh, sorry.
Hi, this is Nell from Bethesda. So, is doing this process, is there any part of this process that we need to look for any coding? Or this is more chart abstraction? Because all I can see are like chart abstraction of when is the blood pressure high and then the second monitor the blood pressure. Okay. Oh, there's an ICD. I saw it. One.
Yeah.
Okay. So this is it. Okay. So we might gonna have a problem with this because we just converted to Cerner, and for now we are getting our charts for abstraction that already have coding on it on the 15th of the following month. That's gonna be our biggest challenge.
I know. So we can definitely work with a different deadline if you need it. Based on what you're telling me, that's what it sounds like. That's completely okay.
Okay.
So there are several ways that you can identify the patient. Shelby went through a couple of examples. One would be if you implement the data collection form along with your debrief.
Okay.
That would be the best way because that way you have the data collected for every severe event along with the debrief that needs to happen. So, you know, you would have that as a way to identify your cases, hopefully most of them. The coding is extremely helpful too to, you know, identify those cases that were missed.
Yeah.
Or where maybe the BP was not checked within those 15 minutes, and as we have it for the definition. So, but yeah, definitely, if you need a different time frame, we can work with you on it.
Yeah, because what we do on the few initiatives before that we are involved in is that we get the list of the patients from our analyst who runs the report. So if it is not coded yet, then it's gonna be hard for us to know which one is gonna be included in the criteria.
Absolutely.
Now, I would just add that Stephanie had mentioned that from A1, that debrief form, that is not copyrighted. We have the rights to share that with all the hospitals. I know I've used it a lot, and it's in our, it'll be in our toolbox, and it was also presented at the kickoff. So that A1 debrief form, if you do it, and then someone submits that debrief form, that could go right along with your data collection, which would be a best practice.
Okay, I will look into that and we'll see.
All right. Well, I know we have a lot of questions still to be answered and we want to get to all of them. So if your hand is still raised, we haven't answered your question, please write it in the chat and hopefully we'll have time.
I'm on a call. Yeah, I have.
I can mute them. Thank you. Hopefully we'll have time at the end to verbally answer them, but if not, we'll make sure that we answer all questions and send out the answers to all of you guys. So keep your questions coming, but keep them in the chat, and we're gonna hand it over to Alexa for a short demo on REDCap submission.
Okay, I am going to share my screen. Let me pull up my prompt. There we go. Okay, can you all see my screen?
Yes.
Perfect. Okay,
Yes.
so this is what the patient level data prompt form will look like. Shelby, if you could, well, I'll drop the link in the chat here right now. You all can practice on this if you'd like for about 2 weeks before we delete it. This is a demo only. Any data put in here will not be reflected in your reports. You shouldn't enter real data. It's not going to be used in any capacity. But if you run into any errors or you have any questions, feel free to email Shelby and I, and we can work through that. And then also the measurement grid right here, there's a link to this so you can review it. It has a lot of specific detailed instructions and actually answers some of the questions that I've seen in the chat so far. So I'm just going to go through and put in a fake patient situation. Here you'll put your hospital name. It is quite a long drop down. However, you can start to type your name, your hospital name, and choose it that way. Again, you'll put your study ID here. It is a triple digit 001 code. As you saw, you should have 15, up to 15, I should say, patients per month. So in theory, at the end of January, you'll end with 015, and it should be consecutive across the initiative. So the next month will start with 016. So discharge month, I'm just going to put June 2024, and I'll say that it was a Saturday, Sunday, or holiday discharge. I have my notes over here so that I have a situation that clinically makes sense. So I'm going to say that this patient was 35, and I'm going to say that she was pregnant at the time of the event. So you'll see that 2 more questions popped up asking what the patient's gestational age in weeks was, and what, if applicable, if they did deliver, what the patient's gestational age was in weeks at the time of birth. But if you choose postpartum, those go away, and now we're asking you how many days postpartum was the patient. So just keep that in mind. So I'm going to say that she was 30 weeks, and this patient did not deliver, so I'm going to leave this blank. For ethnicity, you have these 4 options. I'm going to choose non-Hispanic. For race, I'm going to choose Black, but please note the square looking buttons are multiple choice, so you could choose as many as you want. If you choose other for any of these questions on this form, you must type in an answer. It will not let you submit it without typing in an answer. If you're choosing other because you don't know, choose unknown instead. Primary language, I'm going to put as English, and insurance, I'm going to put as private, but again, these are multi-choice options. Because this patient didn't deliver, I'm going to choose not applicable, but you do have vaginal, scheduled C-section, and emergency C-section available. And then here's where you would put diagnosis at delivery. I'm going to put chronic hypertension, but you can choose as many as applicable. So here's that grid where some of you had questions about where to put in time and location for severe hypertension readings. I'm going to go through this with my notes. Let's see here. So this first line again is when the first severe hypertension reading occurred. We want to know what time and what location. For this time, it must be in a 24-hour format, and it must have the colon between the hours and the minutes. It will not let you submit without it. You can type it in, or you can click this little clock and do sliders. But either way is fine, but it must be in a 24-hour format. So I'm going to say her first reading happened at 15:32 in the EMS. And then I'm going to say that her confirmatory severe reading occurred within that 15 minutes at 15:45. Whoops, that's not 45. And that occurred at the OB-ED. Because this was her first reading in an OB unit, this confirmatory reading, I'm assuming based on this. If you know something different from the chart, then this may look different, but in this case, that was her first reading. I'm gonna mark this as the same, 15:45, and it occurred at the OBED. I'm gonna say that her first blood pressure medication was given at 1600 hours. And that occurred also in the OBED. And then finally, she stabilized 2 hours later. Let me do the slider so you can see this at 1800. Sorry, I'm working with a mouse I don't normally work with, so. And I'm gonna say that that happened in antepartum. So that's what that medical management severe hypertension reading looks like on the REDCap. And just a reminder, this is only for the first severe hypertensive event. Here is where you're going to start building out your chart for your medication. The first question that you'll have to answer is which medications were given. And you'll see in a second that as you answer those questions, it will fill out the form for you. That way you only have to answer questions on medication actually given. You don't have to worry about the other medications. As a note, if you click something like nifedipine and then you say also none, it's going to give you an error. If you choose none, you cannot have anything else chosen. And if you choose none, these questions will pop up requiring you to tell us why the patient was not given medication and why they were also not given magnesium sulfate. So in this situation, I'm going to say the patient was given labetalol, nifedipine, and other hypertensive. If you choose other hypertensive, you must put in the name of the medication. Full disclosure, I have no clinical background. I forgot to ask about another antihypertensive, so I'm just going to type in other antihypertensive. Please don't put that. But I wanted to show you that as you type in the name here, you'll see it pops up here into the table for you to answer the protocol question. And of note, I left magnesium unchecked just to show that you'll have to answer why magnesium was not given, even if other medication was given. So I'm going to say that protocol was followed for all 3 medications, and nifedipine was the first medication given. This second column over here, you should only check one. We're just trying to find out which medication was given to the patient first. And then for the reason the magnesium sulfate was not given, I'm going to put not documented. But again, if you choose other, you must specify the other reason. And if you hit not documented, you can't have any other options given. That way we kind of are forced to avoid conflicting answers. Under medical management monitoring, I'm going to choose yes, even though this is very unlikely for hypotension to occur, but I'm choosing yes to show you that if you choose no, nothing happens, but if you choose yes, there are 3 extra questions that we want to see. We want to see, was there a corresponding deterioration in fetal heart rate? I'm going to say no. Were interventions for hypotension administered? Yes. And then was the C-section performed due to hypotension? I'm going to say no. But I just wanted to show you, even though it's unlikely, that if you do choose yes, there will be 3 more questions that pop up. Under adverse maternal outcomes, I'm going to choose none, but you could choose any and all that apply. And again, if you choose other, you must specify in writing. And same exact thing goes for adverse neonatal outcomes. You can choose any and all that apply, but I'm going to choose not applicable because the patient did not give birth in this situation. 2 simple yes or no questions. Did the physician RN debrief? Yes. And if it was an SMM case, was an interdisciplinary case reviewed, conducted? I'm going to say not applicable. This was not an SMM case in this fake world. And then finally, you have discharge management. This is the yes or no question that I went over before. Were verbal and written postpartum.
My team knows that. And I said, but you know, us talk.
Whoops. Sorry. Were verbal and written postpartum warning signs given? I'm going to say yes. Was a patient verbally debriefed on their severe hypertension? Yes. Was the patient discharged on medication? If you hit yes, a second question will pop up asking if they were provided to the patient prior to discharge. I'm going to say yes. I'm going to say they were given a blood pressure cuff and you did a postpartum discharge assessment. And then I'm going to check that this is a check all that apply on how many days after discharge were appointments scheduled. I'm going to say the blood pressure and symptoms check occurred within 3 days and she was scheduled for follow-up within 8 to 14 days. Critically important. Go ahead and put your email in here so that we can see who filled it out, but it also will give you a link to fill this out again. If for some reason you don't have a chance to complete this form start to finish and you need to come back to it, you'll hit this save and return later button, which I'm going to do right now. It will give you a return code, which is what Shelby was talking about in that chart that we have that will give you where you can write down the patient and the return code. You'll want to save this somewhere. This will allow you to come back and finish and submit your data for the form that you're on currently. So I'm going to copy this, hit close. You could have yourself emailed a link to finish it, but we suggest using the return code. It's easier. Or if you change your mind, you can continue the survey now. But let's assume that your kid has soccer, you have to leave, there's an emergency, you have to come back the next day. What you'll do is you'll go to the exact same link to go where you would to fill out the form originally, and you'd come up here to the top right where it asks if you're returning, and you'll click continue the survey. Here's where you'll put in your return code, and it brings you right back to the form that you were filling out. So this is all filled out, it's ready to submit. Everything looks good. I'm gonna hit submit, and it gives you the same return code. It also gives you another place where you can find my email and Shelby's email if you have questions or concerns or something happened, anything. And then because you're submitting up to 15 patients, you'll want to hit this submit for another patient once you're ready. That way you don't have to go digging for the URL every single time in your bookmarks or your email. You can just hit submit for another patient and it pops up and you're ready to submit your study case 002. Any quick questions on this?
All right, thank you, Alexa. All right, so we're gonna kind of try to go through this next part kind of quickly so you can have some questions at the end. Can you see prompt data types?
Yes, sorry, I couldn't find my mouse.
No worries, thank you. Okay. So we just went through our patient level data. I put the link in the chat for you guys to find the measurement grid that Alexa was talking about on our website. So check that out if you've got questions about the sample. Next, we're going to talk about our aggregate patient level data. And these next data collection forms will be submitted quarterly. So for our aggregate patient level data, our very top line is going to have the number of patients admitted for birth. So we're only including women that come in to give birth. The second row is coming from ICD-10 codes. That's the number of patients diagnosed with the preeclampsia, eclampsia, or HELP syndrome. Next, we've got number of patients with SMM during birth admission, and then a number of patients with SMM, excluding transfusions, who were diagnosed with preeclampsia, eclampsia, or HELP syndrome during their birth admission. So again, this is, you're going to find this in the ICD-10 codes, and this is aggregate. So out of all those patients admitted for birth. Next, we have our hospital level data that is also submitted to us quarterly. And this is going to be about policy, guidelines, procedures, and staff education. So structural measures just help us to check in and assess where your facility is on implementation within our initiative. We ask about policies, procedures, guidelines, and workflows. And so to measure these policies, procedures, and guidelines, we have a scale here from not started all the way to fully implemented. So it goes from not started or planning, which a lot of y'all might submit in your baseline in January. Then it goes up to started implementing in the last 3 months. Implemented, which is less than an 80% compliance after at least 3 months of implementation. So it's not quite routine practice. And then lastly, that fully implemented, which we hope to see towards the end of the initiative, is where this is a routine practice and we have at least 80% compliance after at least 3 months or 1/4 of implementation. So that hospital level data sheet that you submit quarterly into REDCap is going to look like this. We've got this on our website too, if you can take a preview look at. And you've got our scale from not started to fully implemented on the right. So each quarter you'll choose one for each line. Then we're also reporting on a cumulative percent for staff education and training. So each quarter you'll report on the percentage of nurses and physicians that have received education on accurate blood pressure measurement and assessment, severe hypertension, preeclampsia policy guidelines or procedures, respectful care and commitment to respectful care practices. If your hospital doesn't already have something along the lines of respectful care implemented, check out our toolbox online for trainings. During the MFC initiative, we, FPQC and our partners, we put out a training for respectful maternity care that you guys can use and adopt to fit your education team and your QI team. So for ideas for any of these educations, please check out the toolbox. We'll have more information in prompt, as well as MFC for your respectful care. All right. So next we are going to talk about our QI monthly cycle. All of you will have monthly check-ins with your coach mentors and your other hospital teams. At these coaching calls, before we even get to our coaching call, you of course submit your data. You're going to review your data. Alexa and I send you monthly reports for you to take back with you to your team to assess where you guys are at. So after you discuss and disseminate that data report, then you can identify areas for opportunities. You can create your PDSA or your plan, do, study, act cycle, where you might take one small test of change and see how that goes and adapt it with more and more patients and or staff, depending on the subject of your PDSA. All right, so as we wrap up, we have some important requests and dates. We have 25 DUAs completed right now, so thank you guys so much to those of you who already gotten your DUAs in. 66 of you still need to submit your DUAs, so reach out to us if you're not sure what process you are on that DUA completion. Let us know any changes in your prompt team. We are collecting emails and we're creating contact lists for all of our correspondence going forward. So let us know if there's any changes. That hospital level data form is going to be due in December. This is your baseline. So it's completely okay if all your process measures are at, not starting or just planning. We totally expect that right now. So you'll get that link to submit that once your DUA is completed. And then patient level or that monthly data abstraction collection will be due starting in January. That'll be due February 15th. So the first month of data collection for patients starts in January and will be submitted to us by February 15th if you are able. If that date is not working for you in your hospital, please email Alexa and I, and we can work out an alternative due date for all of you guys. And lastly, here's our emails for any questions, Dr. Rubio's, mine, and Alexa's. I know we're getting in, we are at 1 o'clock now, so please write any questions that you have in the chat. We're going to take all of them and find the answers and get back to all of you with those answers. Dr. Rubio or Alexa, did you guys have anything else to add?
No, we are at the top of the hour. We're extremely thankful for your participation. I am more than willing to stay with some of you if you would like to, revise some of this or have additional questions that we can answer at this time. But for those of you that have additional commitments, we appreciate you all. We will come up with a frequently asked question document. So it will be available to you all. And we will have complete documentation and the forms and everything that you need to collect your information come January. That will be shared with you next week. So that is readily available for you. The other thing we do have is the link to the survey. Alexa showed that to you. That was used for the demo, but you can play with it if you would like to. We will change the link, the formal link afterwards. So don't submit any real data to it, but if you want to play with the link, see how it looks, see how it feels, if you have never used it before, it's available for you to do that as well. That will be active for 2 weeks, and then we will take it out of the web, and then we will create an additional link that will only be available for those that complete the data user agreement. So that's about it. Thank you so very much. We appreciate you all. We're going to stop the recording now, and we're going to stay for those that have questions for us.